the COVID epidemic, the technology and the science around it. I'm Gideon Lichfield. I'm the editor-in-chief of MIT Technology Review. And with me today is Cyrus Shahpar. Sorry about that. Cyrus is the director of the Prevent Epidemics team at Resolve to Save Lives. And before that, he was deputy lead of the CDC's Global Rapid Response Team, and he worked on the Ebola outbreak in West Africa. Cyrus, thank you so much for coming to join us.
Thanks for having me.
Didn't hear it all that well. Can you try and maybe come a little closer to your microphone or adjust it?
Yeah. Sorry, 1 second. Can you hear me now?
Yeah, that's better. Thank you very much.
Okay.
Great. So you're the director of Resolve to Save Lives. Tom Frieden, who used to be director of the CDC, wrote an op-ed in The Hill recently that we shared with our audience about how the CDC is being sidelined. Can you talk a little bit about that? What do you think are the major flaws in the way that the US has been handling this pandemic that you think might have been avoided if the CDC were playing a more prominent role?
Sure. So coronavirus, is a respiratory disease, and many of the world's experts in respiratory diseases are at the CDC, which is the US government's public health protection agency, essentially. So this is the group that has expertise in things like coronavirus and should be providing ongoing daily updates to inform the response. I think in any kind of emergency, we have things like incident command and incident management, and there's clear structures and clear overall leadership and an organization that we've used in countless emergencies, all around the world. So I think that structure perhaps hasn't been in place throughout, since the beginning. I think it was unclear based on, things like the task force who was involved, that CDC, the experts, were having continuous input into the US government's response. So I think, it's kind of like saying, I'm an expert in that I'm going to be managing something, but I'm not going to talk to the people who know the most about it.
Yes. What sorts of mistakes do you think might have been avoided if the experts were more looped in?
Well, I think you can go back and look at, say, quotes from the lead of the National Center for Respiratory Diseases, Nancy Messonnier, who said in January, this is something we really have to be concerned about. We have to get ready for. In February, similar remarks. And at the time, that was over 2 months ago. So in the past 2 months, what did we do to get ready for something that we know is a huge problem right now, that is a pandemic? Were we getting the healthcare system ready like we should have been? Or were we saying we're okay with 100 cases, our case counts are good? Those were the kinds of messages that were coming out of the national leadership, not necessarily based on science and knowing that it might be good now, but based on what we're seeing in China and other countries in Asia, it's going to get a lot worse. I think you're on mute.
Oh, I am. Thank you for that. Let's talk a little bit about the epidemiology of this outbreak. I mean, it seems like we still don't know some really basic things about this virus. We still don't know what's called the reproduction number R0, which is how fast it spreads, or how many people get infected by each person who has it. We still don't know the fatality rate. These are some basic numbers that tell us just how deadly the epidemic is and how quickly it spreads and how many people it's likely to kill. Why is it so hard for us to still have these data? Yeah,
I mean, I think that we do have some kind of estimate of R0, and somewhere sitting around 2 to 2.5 right now without intervention. On the case fatality rate side, certainly we're seeing globally somewhere on the order of 4 to 5%. But huge variation across countries, north of 10% in Italy, under 2% in Germany. And why are we seeing this variation? Certainly there's reasons that could be driving it, like the age distribution of populations and the testing. But there's been some good modeling done on what the actual case fatality rate is, somewhere between 0.5% to 1.5% essentially, if you were able to find all the cases. But the things that we don't know about that we need to know about, things like the proportion of people who have it that don't display any symptoms, that could be transmitting disease. That kind of information has huge implications on how we control it, who we test. So I think that information is especially important to find, and we need to find out more about that in the coming days. Sorry, the CDC, I think, came out with a number recently where it said that about 25% of people who have it are asymptomatic, but it's not entirely clear to me where that number came from. Do
Do you have a sense of what?
There's some studies from the Diamond Princess cruise ship. They did a lot of testing from Korea as well, from Singapore. It's the places that do robust testing, and I know Iceland is doing it as well. There was also a town called Vo in northern Italy that tested everybody in the town, 3,000 people, even though people told them not to. So they're picking up people that didn't have symptoms at the time of testing. Now, some of those people were what we call pre-symptomatic. So they went on to develop symptoms later. We just caught them in a period where they tested positive, but their body hadn't developed symptoms yet. And then some of those people were truly asymptomatic in the sense that throughout the course of their infection, they're not developing noticeable symptoms. So there are some sources for that information, but we also need serologic testing to do a better job of this.
Yeah, so let's talk a little bit about that. This, I think the the FDA approved a test, I think yesterday or the day before, for testing for antibodies, serologic testing, so that people can find out if they've had the virus, if they've had it in the past and recovered. So what sort of scale of testing would it take for us to get a really good sense of how widespread it is? How many people would we need to test?
We should have massive testing in place. Throughout the country, the United States, you see successes in places like South Korea that have had massive testing, because it informs things like, what the burden is in a community, being able to know who's safe to go outside. We still don't, I'd say, have 100% answer on whether or not you can get reinfected, which is a huge problem. We need to learn more about that too. If you can, then that has implications for vaccine development. We don't have a reason to believe, I would say, that you can get reinfected. We know SARS did confer, a year to two of immunity, and MERS more than that, 2 other coronaviruses. But we have heard reports that, people who tested positive, then were fine, and then now negative, and then positive again. So we need to dig a little bit deeper in that. But we really need massive testing before we're saying we turn the faucet on again and let people go out into society and kind of relax some of the physical distancing measures. We really need to have massive testing available.
Right. But to get an idea of how many people are really infected, you probably could, am I right in thinking you could just test a few thousand people? It would be like taking an opinion poll to get just
you could, if you wanted to estimate, say, the proportion of people that have the infection, you could do that. But if you want to inform people, who work in a school or work in a nursing home, and let them know, hey, you shouldn't go to work. You might be younger, you might feel fine, but you're going to go interact with people that are highly vulnerable. To make those decisions, we need to have testing available.
Right. So I'm just going to remind the listeners that you can ask, if you're on the Zoom meeting, you can ask a question. And there are also other ways if you're listening on Facebook or YouTube. On YouTube. If you're listening on YouTube, you can also ask questions in there, and we will see them and channel them to Dr. Shahpar. So picking up on that testing question a bit further, what do you think happens? What do you think starts to happen when, some countries are already doing the serologic testing. The US is a little behind again, but what do you think starts to happen when some people are being let out because they've shown that they're immune, and some people are still being cooped up? How do we handle that? How do we handle that socially? How do we handle that politically? And are there any experiences that you had, maybe with Ebola, for instance, on how that works? Yeah,
in Ebola, it was useful to know who had antibodies because they could be put back into the workforce safely. So knowing who's more protected, essentially, to be able to do critical functions is important. So that's one of the benefits of having that kind of testing available. I think this is still, coronavirus science is at an unprecedented pace. The number of articles, and a lot of them are in preprint. They're not through peer review. So we see the articles. It doesn't necessarily mean they're all, to the quality of what we would normally consider scientific review, but they're providing lightning speed information. So we need to process all of this to get a better sense of how things might change. So something I might say, I've been on interviews for the past 2 months, something I might say today, tomorrow we get a new study that says something else. So it's important to just have that caveat in general for the interview that our understanding of coronavirus is evolving every day.
Yeah.
And that's it.
This is one of the things that's really striking, is it feels like every day we learn a completely different perspective, and the things we knew a week ago are no longer true.
Yeah.
A couple of questions from the audience. Someone is asking, can anyone get the virus, or are some people naturally immune? Do we know of any natural immunity?
I haven't seen any natural immunity. in pandemic modeling, we look at this as a completely novel virus, never been seen before in humans, so there's no natural immunity. I'm not aware of any studies that show that.
Right. Going back to that sort of uncertainty about numbers, so there is, the White House released some projections a day or two ago where they talked about 100,000 to 240,000 Americans potentially dying.
Yeah.
And I think one of the things that maybe was lost a little with that announcement was that those projections, as I understand it, assume that the entire country basically goes into lockdown, like China-style lockdown. I don't know if that's, maybe I've misunderstood exactly what the requirements were, but that it was assuming that things are happening that are not happening today.
It does assume that within a week, those places that haven't implemented measures will do so. That's not a given, certainly. And the thing is, we say China-style lockdown. There's implementing the measures that we have been doing, especially like in Washington and California, places like that, early on. But then there's things that no matter what we do, we're never going to get to the China-style lockdown. You know, the China situation, Hubei province, more of a one area, and shutting down train travel. Whereas here, you know, train travel is not a big part of how we move from state to state. The geography is different. We drive a lot. So it's, in terms of having people go out of an area, it's going to be much harder to do that here in the United States, even if everything else is in place.
But also in Hubei, or at least in Wuhan, they were not letting people leave basically their buildings, their residential compounds, unless they could show that they were, either they had to, or, so those were very tight restrictions even within the city.
Yeah, enforcement is a big issue.
And so how important is that? How much of a difference do you think it would make? New York, for instance, would it make a big difference if it shut down the public transport system and didn't let people move around?
I think we need to see, who's, the thing is, critical workers are going on the public transport system.
Right.
Hopefully those systems are being cleaned. I think that would cripple potentially some of the response efforts. From what I've seen, this is anecdotal from my physician friends in New York, showing me pictures of the subway with them on it and nobody else on it. At the same time, people who can't afford not to work are riding the subways and, in certain rush hours and being together, and that's a risk. And unfortunately, they have to for their livelihood. There's no other solution.
Right. But we don't, I guess, do we have enough data to know that if you could shut down the public transport, it would make a lot of difference?
We don't have enough data to know if it would make a lot of difference.
Right.
We know that, it's one of those things that can't hurt. Obviously, it's going to improve a bit, but then you have to weigh a lot of the non-health costs as well of taking that action.
Right. And in the US, what would be the impact of, the fact that it's reaching different states in the US at different times, and every state is going to peak at a different time. What would be the consequences if some states clamp down while others have looser restrictions, and then the states that clamped down earlier loosen their restrictions while other states are now clamping down? If you have this kind of patchwork approach, does that make it harder to contain or to flatten the curve? Certainly.
It means that the whole situation for the United States is going to last longer, and more people will die that don't have to, because these they're very connected, the states. It's not, you can't isolate states. We're not at the point where we're going to stand at the borders of the states and say, you can't come in here. I don't know if we'll ever get there. But the US is kind of a reflection of the world. You have the New York cities, which are kind of like Lombardy, Italy, or Wuhan, China. And then you have California, Washington, which potentially, hopefully Washington more so right now, look more like the Singapores and South Koreas. But the thing is, we need even application of all the interventions in the United States. Otherwise, we're all at risk. It's kind of like health security in general. If one country's risky, then everybody's risky.
Yeah. So that actually leads me to a couple of other questions, which are about what are the implications for the US and for Europe when this pandemic starts to really take hold in sub-Saharan Africa, for instance, or in India. Because one of the things, there's a couple of things going on there. One is in a lot of those countries, or in a lot of the cities, especially in those countries, social distancing isn't really an option. There isn't even sometimes running water for people to wash their hands. The idea of shutting down the economy just is unthinkable, and there aren't enough testing kits, and there aren't enough medical facilities. Yeah. So talk to us a little bit about, first of all, how you see it playing out in those countries, And then what does it mean for Europe and the US if, whilst they are shutting down, the pandemic is raging elsewhere?
Yeah, globally, again, it's like the US situation where there's variability. It means that globally, we're not going to be able to say we're free from the virus, if it's smoldering in other places. And unfortunately, it could be that some of the countries that have successfully implemented measures shut off the other countries and unfortunately leave them to deal with their own situations. We have a program to support Africa specifically. And we know there's going to be a lot of infections in Africa. We know there are limitations to take care of sick patients. We know that in some capitals, they have 50 ICU beds, that's it. So they're not going to be able to treat the sickest patients. We also know that they have a lot of potentially severe reactions to trying to implement what we call non-pharmaceutical interventions, to say you can't go to work, you can't go to school. There's violent reactions to that have happened already. And so what we're doing is trying to inform governments on, what does the public think? We're doing rapid polling and things like that. If you were to do this, what are the repercussions? Just so they can plan better. But no matter what we do in those areas, we know that there's going to be limits, and unfortunately, they're going to have a lot of infections. Perhaps one of the only two things that Africa has going for it are, one, they deal with infectious disease events all the time. So there are some systems on controlling outbreaks there. And two, the age distribution of their population is much different. Italy has 22% of people over 65, which is the most vulnerable group, over 60, sorry. And Africa is around the order of 3 to 4%. So, right. So potentially they'll have less deaths potentially.
If you have a big outbreak, I mean, if we have very widespread infections in some countries in Africa, let's say, could it be that there the virus mutates more because it's spreading further, and therefore then new strains are introduced that then can come back to Europe and the US?
Potentially, yes. We haven't seen a lot of mutation from what I've seen in this virus, but certainly everything's on the table, with this virus. We try not to make projections at our organization that are 3 months out, because there's so many things within 3 months that could go wrong, like a big mutation, or it could go right, like we have a therapeutic option that seems to work well. Right. But we know that April in particular is going to be a time of a lot of infections and unfortunately deaths. And we start in, most countries were early in their curve at the end of March. And so, the infection is going to spread. And hopefully the interventions will start to show some effect on flattening or bending the curve, however you want to put it.
Right. Got a couple of little factual questions here in the chat. Do people with different blood types react differently to the virus? Have you seen any evidence of that?
There was a small paper in preprints around people with blood type A versus O, and one being more susceptible. I think we're going to look at, we have a weekly science review at our organization. If anybody's interested, you can go to our website, and we kind of summarize the science and tackle some questions that everybody's asking. This is one of them this week. So we'll have a science review on Monday that looks at this, but there was a small evidence of that. And ultimately, to be honest, it doesn't mean that if you know your blood type, you're going to do something different. So practically, it's not very useful necessarily, but there was a small paper that did show some evidence of that.
Right. That leads me on to another question, which is, you, like us, like everybody, is deluged with information. What do you do to manage your information diet and not get swamped?
Yeah, I mean, it is getting more and more swamped. Aside from hiring more scientists, which we're doing and have done, and to build out our team, I think it's also, finding the information on COVID that's reliable is challenging. When you're in medical school or scientists, you learn to go to PubMed, for example, a library resource to look for articles. This is not the way you're going to find out information on COVID. You will find things from New England Journal, Lancet, these kinds of things, but a lot of it's in preprints. There's over 650 articles, I think, today on preprint. So how do you sift through and you have to have a good eye for judging, the quality of kind of a hypothesis and how they answered the question, and then going honestly to Twitter and following people who follow this and what studies are they highlighting, and just being more and following media articles and interviews with people. It's more of a broad effort to keep on track of the latest science related to COVID.
Right. Another audience question. I know this is something that gets discussed a lot. Do we have any evidence that cases will decline when the weather gets warmer?
I'd say there is evidence that that flu viruses prefer certain climates. and that does happen, in the summer. We don't know this is a coronavirus. We don't know. I think most experts will say that it could decline, but it won't be significant enough to change the course of what we're dealing with. So nobody is planning around that. I think in the response, people are basically, if it happens, that's great, but we have no strong evidence to suggest that will happen. So honestly, it's not a part of the ongoing discussions, on a daily basis.
Right. I've got another question from someone who I'm guessing works in public health, who is asking, in Africa, there's clearly massive implications for other global health programs. In other words, when COVID is taking over everything, it disrupts the work that other public health organizations are doing on other diseases.
Yeah.
And so the question they're asking is, what do you think organizations in that sector should be doing now? What do you think is the most pressing role for them?
Yeah, I mean, it's a huge problem. I mean, in Ebola in West Africa, more people died from the consequences of Ebola than actually from Ebola. Missing routine health appointments, missing vaccinations, all of this stuff was more from a health standpoint. And also, I think one estimate was 18 billion of $53 billion in cost was non-Ebola cases. So it's a huge problem. And, I think a lot of the people running these programs in countries and also people who support these programs are looking at how they can pivot their programs to supporting COVID, which is the topic of right now and the urgency right now and has the attention of all the ministries of health, but also perhaps, make sure they don't completely, look toward COVID without remembering that they have significant burden from other types of diseases, TB, malaria, HIV, these things. How can we kind of find the synergies so that we strengthen COVID response, but also make sure we're not ignoring the things that kill people today? That's a challenge. And it really depends on what the disease is, what the program looks like. Can we use lab capacity? We built a BSL-3 lab for TB. Can we use it to test COVID? These kinds of synergies to help support both, I think, are important.
Right. A couple of the questions I'm getting, I think are, I'll ask you them, but they're also, I think, suggestive of the level of just uncertainty that people have about this, despite the fact that there is lots and lots of information out there, fairly reliable information. So here's one question. An MIT study, I haven't actually seen the study, an MIT study apparently suggested that 2 meters or 6 feet isn't a sufficient distance for social distancing. Have you seen anything around that, around suggesting the virus can travel further? Or is this about, identifying a reasonable limit that reduces the risk by a reasonable amount?
Yeah, I think it's a reasonable limit with the assumption that the majority of transmission is respiratory droplet. And that's the breathing zone we typically have. Now, if it's windy outside or if you're projectile coughing or these kinds of things, then you don't want to be within, farther than 2 meters close to somebody. There was a study looking at a choir that recently showed an outbreak in a choir where it suggested that there was airborne transmission because they were meticulous about the way they interacted, even though they met. And there are studies that show, for instance, loud singing causes airborne particles to be developed, or loud voice. So that study actually suggested that there was airborne transmission in that setting. But overall, so it's possible, there's a spectrum of droplets to smaller droplets to aerosolized particles. It's not just on or off. And medical procedures also create aerosolized particles as well. As you saw, there's a New England Journal article showing that aerosolized particles can last in, I think, for 4 hours, they suggested. So it really depends on the setting, but the majority, the typical, distance, in a normal setting, absent of them shouting very loudly, 2 meters seems reasonable.
Right, okay, but no going near people who sing loudly. So how do you think about, or how do you advise people to think about the level of risk? Because it's, you could take an infinity of precautions to eliminate the last possible risk. And, I and my friends, we discuss, are you washing all of the boxes that you bring home from the store? Do you take your clothes off when you come in and leave them by the door? Do you,
Yeah.
And so there are so many precautions that you could decide or not decide to take. How do you advise that people think about the way to manage that?
Yeah, it kind of depends on what they're doing, if they're healthcare workers, if they're not, what their risk exposure is, Are they going outside every day for some reason other than going for a walk? Are they trying, do they have are they essential for some reason and have to interact with society? The more you're exposing yourself to potential transmission, the more you should take precautions like, taking, I know healthcare workers who take off their clothes before they go in their house, and make sure everything's clean, wipe down their car, wipe down their stethoscope, wipe down everything, because they have a higher risk. I think, with the boxes, that's come up a lot in terms of, Amazon boxes and things. I mean, the New England Journal article showed that it's 24 hours on cardboard, but if the guy who delivered it isn't gloved or maybe was wearing gloves, but touching everything anyway, the risk is there, but is that a reasonable risk to be concerned about? I would say most people would say no, not right now. I mean, you could just have a good practice where, you pick up the box, you open it, that you wash your hands after before you touch everything else, after you dispose of the box, that kind of thing. It's just a good practice. But the risk is very low compared to, say, going out in society, touching the elevator button, going to a crowded market, these kinds of things. So yeah, it's a spectrum.
A couple more audience questions. This is, I guess this is the question. When do you think the pandemic will end? Are we talking about months, a year and a half?
It will end when we have a vaccine, if it works. So most people will say 12 to 18 months for a vaccine. But that doesn't mean we can't have somewhat of a return to kind of the way we were, with maybe with some modifications, essentially a new normal earlier than that. And a lot of that timeline depends on, how we are about shutting down right now, how we are about getting ready during the shutdown. And this is on the government, this is on healthcare systems to prepare public health to get ready to test aggressively and trace contacts aggressively. Do we do that over the next month or two while everybody's hiding inside? So that when we open things, there's not a big resurgence. That's a big thing. And then the third thing is therapeutics in terms of medicines. Are they effective? Are they not? We'll have some information on that, hopefully, this month, as soon as this month, in terms of more robust evidence. Right now, unfortunately, there's decisions being made or magic bullets being described that aren't based on robust evidence for therapeutics. And we shouldn't be rushing to hydroxychloroquine when, it's based on 150 patients.
Right. A lot of people are talking about the kinds of measures that they were taking early on in China and South Korea and Singapore, where they're using both very thorough case tracking, so monitoring, finding people who've been exposed and then tracking all of their contacts, and also data, surveillance, monitoring people's movements through their cell phones or through an app, requiring them to give up their location history in order to be allowed into certain places. So obviously, there are lots of civil liberties questions, but do you think that is something that would help, that we should be adopting in the US? And how do you think we would handle the civil liberties problems of giving up that data?
Yeah, I think there's certainly there's things that are being done in other countries we will never probably do here because they're just too invasive in terms of privacy and people not wanting to opt into that kind of thing. And I don't think we are in a position to mandate that. I don't know. Things change all the time with this response. It could happen, but I think there's things that we can do with say apps and other devices to improve the contact tracing we have. We don't even have the basics in the United States to be able to contact trace like we need to. China contact traced over 700,000 people, and in Wuhan they had a team of 9,000 people ready to contact trace. If you go to your local state and health department now, contact tracing is maybe a 5-page form, and I go to the house because I'm only usually tracking 10 cases, right? But when we open society again and when we open the faucet and people go out there, we're going to need to track thousands of cases. So that needs to be an electronic solution. So this is one of the most critical things we need to be doing over the next couple of weeks. How are we going to empower in the United States, state and local health departments to be able to contact trace at scale? Otherwise, we can't reopen things because we're not going to be able to drive down the cases. And when they come back, we're going to get overwhelmed again.
So why was China set up to do this? Did they have thousands of people just sitting around in health departments ready to do contact tracing? Or was it?
I mean, I used to work with them on global response. And, we created a U.S. global rapid response team after Ebola, which I led at the end. And when we would coordinate with our Chinese colleagues, I'd say, how many rapid response teams do you have? And they'd say 10,000. And it was just a totally different scale of being able to mobilize the workforce. It's kind of like the hospital is a tangible example. Build a hospital in a week. We don't do that here, but they're able to do that.
Because those people are already healthcare workers, or they simply mobilize people from wherever and train them to do it?
I mean, part of it is that they have more control over, the workers, the government. They have a bigger public sector, I would say, to be able to mobilize from.
Okay, so what would it? I mean, do you see any evidence that the U.S. is starting to think about how to do this electronically? This kind of contact.
We've been a part of those discussions, I think, and we've been advocating for it. I think the problem is, everywhere you go, whether it's counties or states or the U.S. government, we call it the fog of war. There's so much information. They're focused on the 200,000 deaths. They're focused on, right now, and they're not thinking about when we turn things off, what we need to have in place. So that's what we're focusing on and trying to focus the discussion there, because these tools exist in other places. We need to come up with a solution. We need to come up with a workforce to implement that solution. That means expanding the workforce. It doesn't take, you don't have to be a PhD epidemiologist to contact trace. You just need to have a workforce that knows how to use the app and follow up with things. So where is this coming from? How are we going to build it rapidly over in April, essentially? These are all questions that I think need to be answered. And so
and who in the US government is currently responsible for them?
US government is, sorry?
Who in the US government is currently responsible for those questions?
No, it's a mix of things. US CDC is usually the technical agency that puts out guidance. So they could put out guidance that says, when you contact trace, this is the information you collect, how often, who you collect it from. And then, state and local health departments are usually the implementers. They figure out how to do it. The problem is state and local health departments don't have the resources to develop an app. And there is some benefit to having, say, one single platform that can share data rather than having different platforms. So I think this is a challenge this is the kind of thing, the detail that needs to be sorted out. And then in the app itself, I think we start with the basics of whatever we used to do on the paper, we just make electronic. That'll help a lot. And then we can think about things like, do we want to use Bluetooth proximity to figure out, well, who was I near that day? Who does my phone know the other phone that was near? Can we anonymize that? So if I test positive, that the people that were near me get a message. Or even going beyond that would be location-based kind of contact tracing. So that if I was near an elevator button and I got infected later, and then somehow 5 other people came later in the day and they all got infected, then maybe we could have an idea that place is not, there's something going on there, and we could investigate that. So that's an advanced kind of approach.
And so this fog of war that you described, with everybody overwhelmed with information, do you think that is because the US is such a decentralized system, such a federal system, or would it be solved if there were just like a stronger agency, or more resources in the CDC to have created the groundwork for this?
I think everybody's in the fog of war, like, in the world, essentially. Most national governments, because this is unprecedented, and it hasn't happened in over 100 years to this scale. Nobody was thinking that when we heard about 24, and they probably didn't even hear about it, 24 mysterious pneumonia cases in Wuhan, December 31st. Okay, here we are, April 1st, 3 months later, and the world is shut down. It's not on the realm of possibility for most people. So it's overwhelming, and people are more reactive than proactive, I think, because we don't know, and there's a lot we don't know, and we've practiced for things, but we've never seen it. So now it's about applying all the things we've practiced. And so I think the fog of war is an understandable situation that almost everybody is in.
Mm-hmm. Right. And then another question that's come in once you've had it, if you've had the coronavirus, and if you know that you've had it, because obviously part of the problem is a lot of people suspect they've had it because they had the symptoms, but they never got tested because they didn't have to go to hospital, so they can't be sure. But let's say that you were tested and you're sure.
Yeah.
I've heard people asking, okay, can I go out into the community now? Can I go and work in a hospital, helping people? Am I safe to circulate? Am I putting other people at risk?
Yeah, so we hope so. We don't have evidence, but some places are giving certificates out, some countries, that if you've had it and then you test negative, and you have and then you've had a sufficient time to develop immunity and antibodies, that you can go out safely, And as I said, other coronavirus in the past, we've seen this immunity. We just don't know how long it lasts here. We don't know. We have to sort out the reports we're hearing about people getting reinfected. But the assumption is that there is some immunity, and you would be safer in that setting if you've already had it and recovered, and then going out into the community.
Right. I have a question from somebody in Sweden saying, here our leaders have generally quarantined people over 65 and people who have other diseases whilst keeping society going. And there's a strong emphasis on personal responsibility for social distancing. Could the world learn from Sweden? I
think Sweden is a great case study, a natural one, because of the decision to take the approach that they did. We can look to Sweden, maybe if we want to control for weather and different things, we could look to Sweden in comparison to Finland and Norway and see what their growth curves look like. The last time I looked at this a couple of days ago, it looked like Sweden was wasn't performing as well as some of those other places. I think ultimately, because there's so much we don't know about how it's transmitted, we have less control over, even if I'm a good citizen, doesn't mean that I can control whether or not I get infected. If I don't know how it's transmitted, or people aren't even symptomatic and they transmit it. So ultimately, if that's the case, that there's asymptomatic transmission, and that the type of approach that Sweden has may not be enough, to be honest.
Right.
That eventually they'll migrate toward there's a lot we don't know, so we all just need to stay inside right now kind of approach.
Right. I mean, there was this famous study from Imperial College a couple of weeks ago where they modeled different ways of dealing with the epidemic, and they said even if you socially distance older people and people with weak immune systems and so forth, that still doesn't take care of the pandemic. It will still flare. I don't know, maybe that might have been possible if it was in the really, really early stages. I don't know. But the point is, since we don't know how widespread it is in the population, we can't actually tell if those measures work.
Yeah, I mean, and right now, the world, I think in general, Europe, United States, other places, is saying, stay inside. And as I said, this is the time when we learn more about it. We get ready when we release things, we build up the healthcare system, we have massive testing, we do the contact tracing at scale, so that it's a different place when we release the virus again. You know what I mean? Like when people are out, not release the virus, but when people are out and there's more mixing, more potential for spread of infection, we'll be more ready. Do you know more about it?
Right. Do you think that in principle, if we did all of those things right, it would be possible after this initial phase of lockdown, the first 3 months or so, to return to some kind of semblance of normality without having to go into lockdown again in, say, the fall?
It's a good question. I think what we're preparing for is multiple phases of lockdown again. And these need to be data driven. They can't just be, we need to have indicators for each of those things. And we've actually come up with the indicators and released them today in terms of the epi information that needs to happen, that you need to monitor, the indicators for when to lock down, when to not lock down, what you lock down. Because when you release things, you release them in phases, meaning, that you might say, let daycares open first, schools, maybe to let people go back to work before you allow people to visit nursing homes. That's later on, much later, because there's vulnerable people there. So it's more of a phased approach, whereas the tightening or reinstitution of the lockdown is more of let's shut it down, again, because we're seeing cases rise, we're seeing contacts that we don't have any link for, these kinds of indicators, we need to control it and reduce the peak. So we're just going to implement everything.
Right. And what sorts of indicators are those? What sorts of things will you be watching to see what needs to be shut down and what can be opened? Yeah,
so you're talking about when we loosen, they're in 3 categories. One is the epidemiologic information, the trends in cases and deaths, what we know about the cases in terms of source of transmission, do we know? And this all assumes we have robust testing. So it's not an artifact of testing, right? And then in healthcare, does the healthcare system have capacity if we had to double the cases? Are more people leaving than are coming into the system? All of these things are different indicators we could use to determine whether or not the healthcare system is prepared. And then in public health, this is about, can we follow up on cases, all of them, interview them for their contacts? Can we test 100% of symptomatic contacts or close to it to be able to rapidly isolate them so they're not in the population? Because we know that unlike SARS, this coronavirus there seems to be more, the infectious period seems to be earlier in the course of illness, and even up to a few days before you're symptomatic. So the early identification of cases is extremely important in this case. SARS was more of a, the longer you had it, the more infectious you were kind of situation. So it's about the epi, the healthcare preparedness, and then the public health capacity to find and isolate cases. Those are kind of the big buckets of information.
Right. And so the first of those, you really do need the massive testing that you're talking about.
Yeah.
And
you do.
Is that,
and you can see South Korea has massive testing, and they're probably, you know, with Singapore, one of the best performing places because they know who has it. Right now, we don't know in the United States who has it, right? You might have had a cough. I might have had a cough a few weeks ago. Do I have it? I have no idea, you know?
Right. But even in South Korea, I think they've only tested a pretty small proportion of the total population, right?
Yeah,
so,
yeah. I mean, but they've tested around the you know, there was a church incident. They've tested even asymptomatic people that were in contact with them and found some of them to be positive, even though they didn't even know it. But yeah, it's on the order of a few 100,000 tests, I think.
Right. So here you're saying we need to be testing millions of people.
Yes.
US.
We need to be testing millions of people.
Right. We are running short of time. So one last question, I think, about Bolivia, which is in full quarantine, but I think it's a question about poorer countries in general. So for a country like Bolivia that probably doesn't have the capacity to build this kind of contact tracing and all this infrastructure, how would a country like that return to some sort of normalcy after the quarantine if it doesn't have the testing capability and it doesn't have the contact tracing and it doesn't have all of that stuff?
Yeah, it's a difficult question. I don't have a great answer. I mean, this is a humanity versus virus issue. It's not Bolivia, United States, you know, China alone. If all you mentioned earlier, well, what if the other countries are having it? We've done a, you know, or you know, the United States or Europe has done a good job. This is all of humanity needs to come together. So this is where Bolivia needs to get support from maybe those who have learned some lessons and those who have more resources to be able to help control it in the country. So that's one of the things that I think needs to happen, because without proper testing, again, then we're in the situation we're in now. You just don't know. And unfortunately, that means you're going to let some of your population have preventable illness and death, which is just not acceptable. You know, so.
Yeah. And I actually have one more question, and then I will wrap up, which is we've seen the FDA, I think, well, there's a lot of discussion about relaxing regulations and approval processes so that treatments or a vaccine can get fast-tracked or can get tested quickly. You know, the FDA did approve the distribution of these drugs, hydroxychloroquine, which aren't even proven, but it's approved their use on patients with severe cases. So what do you think overall of this idea that there's too much regulation standing in the way of approvals of things that might become treatments?
I mean, I think we're, as I said, unprecedented situation. So the removal of some of those regulations could be helpful to get things, to be able to test them, to get them to market, that kind of thing. I think chloroquine is different in the sense that, you know, it's not a novel drug. We've used it in malaria for a long time. So we know the safety profile. So to say it's okay to use that now for this, okay, that's fine. But if it's a novel drug, we might have to, you know, we don't want to necessarily rush to market and say everybody can use this because we don't know the safety profile. So it's a balance. But I do think because this is unprecedented and everybody wants to find a therapeutic as soon as possible, we will, you know, essentially fast track things as much as possible.
All right. Well, thank you, Cyrus Shahpar from Resolve to Save Lives. Thank you so much for taking the time to join us. And
sure, thanks for having me.
Thank you.
Thanks.
And thank you all for listening.